Also, a very, very common thing that we see in our practice, and it's usually found when someone has blood in the urine, which always raises a ton of concern and a lot of concern, is bladder cancer. So just a few words about bladder cancer. First thing to understand is most bladder cancers are actually not high-risk situations. They're not even really life-threatening situations. Most bladder cancers are non-invasive and they're low grade. And what that means is the cancer is not really trying to invade the bladder wall. And if it's not trying to invade the bladder wall, it means it's not really trying to spread. So I like to put people in really two different groups, really three different groups. People with low grade non-invasive bladder cancer. That person might have blood in their urine. I might look in their bladder with a scope and I might find that. That's going to be something I have to shave off, but it's not going to be something I'm really going to be very worried about. The rule with those, unfortunately, is recurrence. So we have to look out for them and we have to get rid of them as they recur. But they're not really, they shouldn't conjure up the same imagery that other cancers do. Now, there's a second group of tumors. They're not invasive and they're not super high grade, or they might be high grade, but they're not so risky as to be very life-threatening. Those are ones that we're going to have to follow very closely. So let's call that the second group. We may even have to put medicine in your bladder. For instance, medicines called BCG or gemcitabine or mitomycin C. The third group, which is fortunately the least common group, are going to be what we call muscle-invasive cancers. This is real cancer. This is the cancer that should conjure up the imagery that you have. These cancers tend to already have spread by the time we find them 50% of the time. And they may require aggressive treatments such as bladder removal or chemotherapy and other complex reconstructions that I perform. But when there's blood in the urine, if a tumor is found, it's almost always the first variety and not the final variety. So once, unfortunately, I have to inform somebody that they have a muscle-invasive tumor, and if bladder removal is involved, the next question that is not always apparent to the patient is, what do we do with the urine after the bladder is not there? How do we manage that? So we call that a reconstruction. The most common thing that we will do is we will take a piece of small intestine from that patient that is kept alive, and then we plug those urine pipes, the ureters, into that conduit. We call it a conduit. It's actually ileum, a piece of your small intestine. And then urine goes into that, and now that comes out through the skin and into a bag. So that would be wearing a bag. Actually, you find that most patients are completely comfortable with wearing a bag, and that's the option that most patients choose. That's by far the most common option. But there are some patients that that's just not an acceptable alternative to them. In the Midwest, and especially done by doctors that were from the institution that I did my residency at, Northwestern, where several of them went to Indiana. Indiana University was the area that really pioneered the work of bladder reconstruction. That and some sites in Europe and Germany. The initial reconstruction that was offered was actually called an Indiana pouch. This was something that would now for the first time hold urine and not leak. It's complicated. Not many urologists do them. I do them. It's where you would catheterize a pouch. So there would be a small area on your abdomen and you would catheterize it every 4 hours, but you would not have a bag. And that's an excellent solution, and it's the primary solution that I use for women. The next advancement in bladder reconstruction was called a neobladder, and there are many different types of these things. There's not just an Indiana pouch. There's every institution that made a variation called them their own pouch, but Indiana pouch or something called a Coke pouch is the most common pouch that you have to catheterize. Then there are the neobladders. Now this takes it to the next step, where now there will be a pouch that holds urine, but it's connected to your actual urethra. And now you can urinate through your urethra, standing up, etc. It's not something that I offer on women because unfortunately it just doesn't work well in women. Most commonly you just can't urinate. They can't empty that neobladder. In men, the problem is you tend to leak some. So there can be a price to be paid to have a neobladder. There are things we can do sometimes that improve the quality of life with this, called a prostate-sparing neobladder, which I've performed and I do perform. But a neobladder in general is a way for us to beat the system. You have to go through getting your bladder removed, and we hopefully cure you with that. But we want to give you the best possible quality of life that makes you happy. And to some, it's worth the extra work that goes into getting a neobladder. And when they work, they are truly amazing.